Welcome, my digital pathology trailblazers. I did not upload last DigiPath Digest as podcast, but today's DigiPath Digest is ready for you right now. Other than me coughing, but I was able to mute myself almost on every platform, not on TikTok or Instagram. But other than me coughing, we covered some cool topics. We covered how AI and the image data set could accelerate medical education specifically. The paper was about radiology, but that would apply totally to pathology as well. Then we talked, there was a comparison of a GPT-4 vision model with the convolutional neural net for neuropathological changes in the brain. And that was cool as well. We talked about how AI can help with your cytology evaluation, how much faster the pathologists and cytotechnologists were when doing that. And we talked about, okay, will AI really reduce cost of healthcare? And that was actually on an example of a prediction model. That was actually on an example of cancer risk discrimination from H&E compared to standard of care based on genetic testing. So without further ado, let's dive into the content of today's DigiPath Digest.
Learn about the newest digital pathology trends in science and industry, meet the most interesting people in the niche, and gain insights relevant to your own projects. Here is where pathology meets computer science. You are listening to the Digital Pathology Podcast with your host, Dr. Alexandra Zhurov.
Good morning. Amazing to see you here again. Good morning, 6 a.m. In Pennsylvania, in Fairfield, Pennsylvania. I am trying to go live across platforms and waiting for you to show up. So whenever you are there, I'm saying hi in the comments. Hi from Fairfield. Let me know where you are dialing in from. I love to hear which, and tell me what time it is. It's 6 a.m. here in Fairfield, and it's going to be different times in different places. And I'm trying to go live on different platforms, but Instagram and TikTok are giving me a hard time. Maybe I need to, let me just give me 1 second to see if I can do Instagram from the phone. To click go live, and let's see, and go live. I don't know if it's gonna be working. Well, Robert, so great to have you, and you are dialing in from Maine as always, and I don't know, so yeah, I'm trying to do on my phone for TikTok and Instagram. If it's gonna work, nobody knows, but that's okay because we're gonna figure it out for next week. It's my super coffee cup. So I know who was last time here from Poland, my friend Agnieszka. She works in Switzerland. She's a veterinary pathologist as well, and she recognized the cup. So as I'm waiting for you to join, let me tell you what happened last week. I had cool guests on the podcast. I had one radiologist, Dr. Nina Kotler, and I had also one veterinary pathologist who works for Aphoria. Aphoria is a sponsor of Digital Pathology Place. They have been sponsoring Digital Pathology Place for, I think, over 3 years already. So since the very beginning when I started this as a company. When you are joining, let me know where you're tuning in from. And last time I was telling you also about that my running coach wanted to quit, and I'm like, oh, why should I run then? He didn't quit, so he has new motivation and all good. So I have new motivation for running, and this is amazing. And then another adventure. It wasn't really an adventure, but since I read this book, it's called by Dr. Lion, her last name. Anyway, she's a physician and nutritionist, forever strong. And there I learned, oh, you start losing muscle mass when you're 30. And I'm like, oh, okay, I'm gonna turn 40. How about I start working out? So Richard, so great to hear you. Fantastic. Okay, good. People are coming in. So let me finish this thought and we're going to go to the papers. So anyway, I'm like, okay, I need to do weight training because she recommends you need to actually train with weights, not just like cardio. And that's like new trend, and you should eat protein. Anyway, but the point was I wanted to have something like we have for this live, where you show up, somebody is live and is doing the exercises and showing the exercises, but it's not just a pre-recorded thing. If it's a pre-recorded thing, I'm like, I have million other things to do and I'm not gonna watch it. Which, by the way, if you're not live, please watch it. Find time to watch it. But basically I was looking for something similar like this, like an online gym, and I couldn't find it. I just had the only thing I found was a personal trainer, which I took one class with, and that was too much for me. I didn't want a trainer. I just wanted like accountability and showing up, and by showing up, reaping the long-term benefits. And I didn't find it. I found the pre-recorded thing, so it's still on me to show up and do the exercises, and I only did it once this week. But that's okay. Better once than none. And welcome. Hello. 64 Cotton Private Limited. That's from YouTube. Perfect. Great to have you. Okay. Let's do it then. We have new paper and sorry, let me coordinate my tablet. The first one was not important, but I fell in love with the second paper from the PubMed alert. And the second paper was titled Improving the Diagnostic Performance of Inexperienced Reader for Thyroid Nodules Through Digital Self-Learning and Artificial Intelligence Assistance. And I thought, wow, this is amazing. If we want to do a startup, let's do this. So this for education, like a digital pathology startup. So this one is in, I'm supposed to be red. What is my, is it black? Whatever, we're gonna be black. Anyway, so it's Front Endocrinology, Frontiers of Endocrinology, something, an endocrinology journal. Let's see if it works. Okay, it works for blue, so I don't know why red is not. Okay, and this group from Korea, this is a radiology group. So we have radiologists here working with us. Can I do it even bigger for you? Yeah, that would be cool. Okay, and I have a superstar here because and a heart. Look, guys, I even have a heart. I loved it, even though it was for radiology. What happened here? Their objective was to evaluate efficacy of digital self-learning, which is fantastic for image-based specialties. When you learn, so image-based is pathology, radiology. I don't know what else. I bet you have some imaging for cardiology, but mainly radiology and pathology. And you basically learn by looking at a lot of images. And mostly it's like in the olden days, it was you sit with another pathologist and you look at the same slides through a multi-headed scope. And now you can do it digitally, however. But basically, you just look at images. They figured out, let's do a tool that is a computer-aided diagnostic tool. CAD, it's called CAD. And what they did last year, they had 26 readers with less than a year experience, less than 1 year of experience in thyroid ultrasound. So we're talking ultrasound, but it doesn't really matter. I think this concept is brilliant. That's why I'm thinking, oh, this is an idea for a startup. From various departments, 6 hospitals participated in this study. So readers completed online learning session. So first they looked at like 3,000 nodules. They looked at it online. So that was totally virtual. What they did then, they were asked to assess a test. So then they got a test of 120. So they learned on 3,000, then assessed 120 thyroid nodules, and they knew the surgical pathology for this. And after this learning session, they used this AI CAD, AI computer-aided diagnostics. And so let me restart. Okay, so they did the test was before and after learning session. So before they got 120, they learned for 3,000, they got another 120, and then they used the CAD and made their final decision on their nodules. And then diagnostic performance before and after self-learning and with AI CAD assistance were evaluated. So what happened here? What are our results? area under the receiver operating characteristic curve improved after the self-learning session, and it improved farther after the radiologist referred to AI cuts. It was 0679 versus 0713 versus 758. So anyway, it was improving. And then the residents who are very much in a learning mode, they improved the AUC and accuracy after self-training, but the other readers didn't. The other readers did not improve after self-training, but when they had CAD assistance, their sensitivity and accuracy improved in all readers. So regardless whether you were a resident who is tasked to work on it and learn it, or whether you were not a resident, then you improved when you had the CAD assistance. I think it's brilliant for training. Imagine we had like for diagnostics or for anything, right? Usually we just have one image from a book, and then you like do it by experience. When you see some cool cases, you share them. Imagine if we had a whole training data set with, I don't know, one type of cancer, whichever, or pathological lesions for me for ToxPath, or anything else, like a whole set where you get them to learn from. I don't know if I have seen 3,000 of a single lesion in my life, and that would be amazing. So anyway, then you have this set, and then you have an AI tool that helps you for your new cases. Amazing. I guess in radiology, you just have this thyroid nodule, so everything is a nodule, and in pathology, it's then subdivided into different diagnoses. But still, what a cool application. I think it's fantastic. That's why I have a heart here. I decided we're not going to be talking about tooth segmentation today, even though we covered some dentistry applications. And what else didn't I want to do? Some other radiology, but I have other cool stuff. We have here a paper titled US Payer Budget Impact of Using an AI Augmented Cancer Risk Discrimination Digital Histopathology Platform to identify high risk of recurrence in women with early stage invasive breast cancer. So this is from a different Journal of Medical Economics, where they actually check, hey, is it going to be cheaper? Is it going to cost less if we use those AI tools? Because everybody says yes, because then you don't need to do molecular, but will it? And by how much? So this particular study was done by here. This is a company, Veranex. No, probably Precise DX. That sounds like a company. I have to look them up. And then we have Brigham and Women's Hospital, Dana-Farber Brigham and Women's Cancer Center, Boston, Massachusetts, and Mount Sinai Health System. So they did that. And the goal here was, our goal was to use so basically check, okay, the normal standard of care versus with AI. So use of gene expression signatures to predict adjuvant chemotherapy benefit in women with early stage breast cancer is increasing. So we use more gene expression signatures. And of course, we have high cost of this and limited access. And then eligibility. I don't know what the eligibility criteria are, but there are some. For these tests, make it less accessible for people. So this study evaluates the cost impact of Precise Deep Breast, an AI augmented histopathology platform that assesses 6-year risk of recurrence in early stage invasive breast cancer patients. So this is like a risk stratification. It's not the classical computer-aided diagnostic where you show the pathologist where the cancer is, where everybody asks like, how much faster can you be with that? They already trained and know how to diagnose everything. But anyway, I still think there's value. But here, what's the risk, right? And their material and methods. So they had a decision tree model that was checking the normal versus the standard of care that we're using now versus this AI tool. So to compare cost of treatment guided by standard of care risk assessment. So what does that mean? Clinical diagnostic workup with or without Oncotype DX. And Oncotype DX is a genetic gene expression signature, gene expression test that is based on wet lab molecular stuff. versus this R, I love those names, PDR, with standard of care in hypothetical cohort of US women. So this was modeling with early stage invasive breast cancers. And they compared cost of everything. Let me get rid of too many lines here. Cost of testing, adjuvant therapy, recurrence, adverse events, and surveillance and end-of-life care. And what I need to do now is cough. My apologies, because my kids go to the summer camp, and I don't know how, but it's in the middle of the summer, and they brought some cold home. And of course, I got it. I think, oh no, it's for kids. And then 1 week or 2 weeks later, I get it, of course, as well. But the question is, how much cheaper was it? Was it cheaper or not? Let me tell you, it was. Spoiler alert, it was cheaper. But interesting, like how they were calculating it was the PRD use in prognostic evaluation resulted in savings of 4 million in year 1 compared to current standard of care, but in how many people? In 1 million females members. So 1 million people, when you do that for 1 million people, you're gonna save $4 million to the current. And now the numbers were, the savings increased to 12.5 million. Again, my apologies for the people on TikTok and Instagram where I cannot probably mute it, but 12 million, and the pre-treated patient costs in 1 year amounted to 19.5 thousands. Oh my goodness, sorry, guys. My apologies for that. It always happens, and then I start crying, and there went the live stream. But give me a chance. Give me a chance, guys. I can recover. I'm not sure. I should make short form content from the moments that I'm crying. Anyway, I'm actually very happy to be here. I'm not sad. Let's summarize this one, right? How much money did they save? They saved 12 million in year 1, and this amounted, no, sorry. Savings increased to 12.5 million. The pre-treated patient cost this is the patient cost. So one patient in year 1 amounted to $19.5 thousand for standard of care and 16.9 for PR. Okay, we have, what do we have? $3,000 difference. I was hoping for more. I'm sorry. I was like, oh, maybe it was 20,000 and now it's just 5,000 or 1,000. Not, but still $3,000 per patient. So for 1 million patient, you save 4 millions. However, they calculated that. But the limitations of the study was recurrence was not specified, and they performed these analyses as best as they could with the assumptions that they had. And obviously, when the standard of care fails once or twice, then you go to a different type of treatment, which is like more expensive. So they calculated that into it. Conclusions: PDXBR demonstrated robust overall savings, but still, healthcare cost in the US is another, in the world, but in the US is another topic that books were written on. And thank you so much for staying with me. And I see more people are joining. One more cough, and we're going back to the next paper. So when you have just joined, let me know where are you dialing in from. And also, if you have any questions, both to the papers and any other questions, let me know in the chat. I would love to answer them. And let's look at the next paper, evaluating the efficacy of a few-shot learning for GPT-4 vision in neurodegenerative disease histopathology, a comparative analysis with convolutional neural networks. So before the vision models, before ChatGPT and the generative AI, convolutional neural networks was the super amazing thing in computer vision, and it was used for pathology as well. So now here they are comparing. Let's unpack, because I'm like, okay, what's few-shot learning? Is there a lot of shot and no shot? Yes, there is. So few-shot learning, in general, it refers, you have a pre-trained model, pre-trained AI, and then zero shot is when it doesn't get any additional domain-specific data. So you would take this vision model and try to diagnose something from neuropathology. Then few shot, you give it a few examples, and a lot of shot, or I don't know how they call it, but I think, no, sorry, zero shot, one shot, few shot. Because if you have to give a lot of examples, then it's what's the point of having a pre-trained model that is supposed to adapt quickly? But basically, this was a few shot, and we're going to learn exactly what the few shot means here. Pathology Applied Neurobiology is the journal that we're talking about, and the group is from the US. We have Mayo Clinic, Jacksonville, Florida, and University of Pennsylvania. Hi to the University of Pennsylvania group, because I'm in Pennsylvania. So what happened here? We have this large language model like GPT-4 Vision. So this is an option of ChatGPT that also does images, right? And this study evaluates the accuracy of ChatGPT for vision in image classification tasks. So this is important, classification. We're classifying images, histopathological images. So we're back to our pathology core competence, and it compares its performance to a convolutional neural network. So what happened? We took 1,520 images, including H&E staining and tau immunohistochemistry for patients with various neurodegenerative diseases. And these were Alzheimer's disease, progressive supranuclear palsy, and corticobasal degeneration. The only one I'm familiar with is probably Alzheimer's, but that's not the point. The point is that they used multi-step prompts to determine how textual context influence image interpretation. So textual context would influence image interpretation, and they employed this few-shot learning. Can I do like trying colors? Few-shot learning to enhance improvement in GPT-4 vision diagnostic performance, and they were aiming at 3 specific lesions: astrocytic plaques, neuritic plaques, and they compared the outcomes to a CNN model YOLO V8. They had a CNN model that does that as well, classifies these different lesions. So what happened? The results the GPT-4 vision accurately recognized stain and tissue origin, but struggled with specific lesion identification. And I'm like, oh, my first thought is like, oh, it cannot detect lesions, then like it's useless. But then I'm like, how much time does it take students to learn recognize the correct tissue and recognize the stainings? You're always like, okay, I want to recognize the tissue, I want to know the stain, then I look for the lesions. So this one is already 2 out of 3 steps in, but that's okay. So then when it was when it was presented with specific images and when it was influenced by the textual context, this sometimes led to diagnostic inaccuracies. What do they mean here? So when they were presented with images of the motor cortex, the diagnosis shifted inappropriately from Alzheimer's disease to the other diseases. But they gave it a chance. They did this few-shot learning. Oh, and we have George from Norway. Hi, great to have you here. Few-shot learning helped. Did it help? Yes, it did help. And the few-shot here, in this case, it was 20 shots, 20, and it helped versus zero-shot learning. So zero-shot was without previous examples, and the accuracy was only 40, but when they gave it 20 examples, it was 90% accuracy, matching the performance of this YOLO model, which required 100-shot learning to achieve the same accuracy. Hey, these slides only versus 100. This is fantastic because, as we know, challenges in pathology and specifically in neuropathology is don't have enough images to train these models on, right? When we think of the trainings that those natural models natural images, and by natural images, the normal images that you can recognize in like dogs, cats, whatever, right? These are natural images, and also natural language is basically the language we speak, so not like code or any other, although code is also included in language. So yeah, GPT-4 Vision works well for neuropathology if you add some examples, which is fantastic, because there's always this question, oh, how domain specific are they? Probably not that domain specific to pathology, but if you add some examples, then it can take all the knowledge that it already has on all the image properties. It did the tissue, it did the stain, like that's already huge for a non-pathology trained model. And then you add examples, few labeled data, and it works. I think this one is going to be our last paper, and it's evaluating artificial intelligence enhanced digital urine cytology for bladder cancer diagnosis. This is also done by a company, AI, which I love when companies do that because they know that you need to publish, and this was published in Cancer Cytopathology, and that's like the first step when you wanted to take your tool on a regulatory pathway. One time I was talking to a digital pathology company. Well, I was talking to a startup, and they wanted to be a startup in the digital pathology space. And I asked them, "Oh, do you have any publications? Can I look at your publications?" And they said, "We are not focusing on the scientific aspect. This is a commercial company." And I'm like, okay, then you don't know who you're talking to, because anybody in the digital pathology company is going to ask you where you publish your data, how you validated it. And they were like, "No, we just want to make software that does this and that." And I'm like, okay, good luck. When you have a publication, we can talk. Anyway, so let's talk about this one. What happened here? I apologize for this cough. It's the worst. Anyway, Mac from California, and they also have here group from Taiwan. There's several groups, several departments that they work with, and maybe that's like part of their company, probably. So what happens here is we evaluated the diagnostic effectiveness of AI X Euro. Did we not just have X, but from a different company? Yes, we did. So anyway, AI X Euro platform, artificial intelligence-based tool to support urine cytology for bladder cancer management. So what does it mean to support? I checked the images, and the user interface is you have a whole slide scan or like a picture of this urine cytology with different cells, and it shows you and classifies those cells into whatever the classification system for urocytology is, and they mention a specific one I'm going to tell you in a second. They had one cytopathologist and and they reviewed 16 urine cytology slides, and they also reviewed the whole slide corresponding images. And they used 3 diagnostic modalities. So they just used microscopy, just normal microscope, whole slide images, and AIX Ural support. And here is the system that they used, the Paris system for reporting urinary cytology criteria, which I don't know what these criteria are, but our cytopathologists and technologists know, and the authors of this particular software, AIX Euro, also knew and incorporated this into this particular tool, right? AIX Euro, the results were, and they did, of course, performance metrics, and the results were, long story short, here from the results, it was better than without, but let's discuss it. This AIX Euro improved diagnostic accuracy by increasing sensitivity. This is crazy because sensitivity, I look from 25, 30 to 63. And I'm like, how can you have this sensitivity? And then I remember this is cytology. Cytology is not anatomic pathology. It's not tissue. So you like work with different sensitivities and specificities and different metrics for this particular test. So here, the sensitivity improved to 63%. Amazing. And they have like different things that they have to evaluate: atypical urothelial, and then suspicious high-grade urothelial carcinoma, and everything improved: the sensitivity, the positive predictive value, the negative predictive value, and they had these specific distinction between different types of atypical cells, and they also had the binary decision, is it atypical or not? So the binary was easier for this tool. And they also demonstrated, this was funny, that the cytop demonstrated higher intra-observer agreement than the two cytotic. I was like, oh, pathologist was better. I don't know if it's better or not. But also, in addition to everything was better with the AIX Euro, it significantly reduced screening time by 52 to 8%. That is nice. That is really good. So the next thing I would want to do here is, can we do this economical analysis for this tool and see if it's cheaper? Because maybe we can screen more and take into consideration also how much it costs to scan and all these different things. But the conclusion here in this one is AI Euro demonstrates the potential to improve both sensitivity and efficiency in bladder cancer diagnostic. Let me check what else. No, we had this latent diffusion last time. So papers for today, and there are other papers. There are other things happening in the world. I need to catch up on reading them because there are a lot of foundational models coming out, and one recently came out by Page, so I need to read that paper. I already started reading that paper. And there is a tool. I think I already mentioned this tool to you. Oh, and we have more people. Hello, Nigeria. Amazing to have you here. So I think I mentioned this tool to you, this literature research tool called Undermined, yes, AI, guess. It's like in contrast to PubMed. PubMed is keyword based. So the keywords that I have now in PubMed are digital pathology and AI. And every week I get those alerts, and we're looking at the email that I get from PubMed, and I check, okay, do I like these publications or not? For this Undermine.ai, it's a different type of tool that searches literature. It's more for when you need to gather relevant information for a project you're going to be working on, for a PhD, for grants, for, I don't know, maybe market research, because you can do market research with scientific literature as well. You basically talk to it, to Chat GPT, and tell this tool what is the problem, and it finds you relevant information, a relevant publication, not just based on the keywords, but also on the relevance. They have some kind of model that assesses this relevant and gives specific points. And the authors of this tool, these are two MIT graduates who are now starting to develop a company around this tool. So they basically sat and made this tool and decided, hey, it's going to be useful, and it is extremely useful. I already used it for many things, but they want to join us. They want to show you the tool next time. So next time they're going to be at the live stream. I still have this live stream, so I'm going to be in Poland. The live stream is going to run at the same time at the moment, and they are in California, so they will have to wake up very early, and it's going to be significant. It's going to be like, what, 3 a.m., I don't know, early, to show us this tool. But they were very excited that they will get the chance to show this tool to the digital pathology trailblazers. So that's one thing. The other thing I was talking about is my YouTube course. Yeah, I have the platform to host it. I figured out how to, scrape all the information from and now I'm going to be working on developing the curriculums. If anybody is interested in binge watching YouTube content in the specific order, based on all the almost 400 videos that I have on my YouTube channel, this course is going to be coming out soon. Let me know if you're interested. Write course in the comments if this is something. It's not going to be a high price point. That's going to be like something that's affordable for everyone who is interested. One-time investment, and every year I'm going to be updating it, because as the year goes, I create new videos and new things are happening. And now this hot topic is foundation models, vision models for pathology. And now maybe I'm thinking, okay, I'm like, still every other paper is, oh, annotations are a bottleneck. But now you start hearing, oh, there are these 0-shot models, 1-shot model, 20-shot model. Oh, maybe you just need like 20 annotations because it already has this vision knowledge to recognize different things. And I'm like, oh, that would be so cool. Some cutting edge things already being obsolete. So this is crazy. I love it. I love how fast it's developing. And the podcast episodes, that they are going to be coming out in, I don't know, a few months, because I do have a backlog of podcasts. But Dr. Nina Kotler, she is the AI main person at Radiology Partners. And Radiology Partners is the largest radiology practice in the US, with 3,000 radiologists, where the average one is 15, or I don't know, few. And I got introduced to her by my friend Joe from Apridia, and Apridia is a digital pathology place sponsor as well. And he said, you need to talk to this person because she's amazing in terms of AI, and obviously radiology is ahead of the curve, ahead of pathology in going digital. And obviously she has like enormous knowledge, publications, has this position, is very active in different, as a chair of different radiology, college of radiologists positions and all that things, all these. So I knew I'm going to be talking to a really high level expert. But the thing that I loved about this podcast most is like how clearly she was explaining these concepts, like to non-experts without dumbing it down. Like I was mesmerized by the way she explained the concepts, and we talked about things like AI agents, which is also like another new hype where you can basically have like a program that programs other programs within this generative AI. But she had a better explanation. Anyways, this is my way of recognizing somebody who's an amazing expert. You have different levels, right? And she is beyond the technical knowledge and jargon when she explains things. Often you'll hear experts or people who are very knowledgeable. It's a natural process, right? The more familiar you become with a terminology, with a topic, the more you start using this language because you're often talking to people who also understand this language. But then taking it a step further and being able, with the same words, to address experts who know the jargon and non-experts without the experts feeling like they are being patronized or talked down to, or any sort of this, oh, do you know I have this expertise? That's an amazing skill. I thought this was fantastic, and we ran out of time because obviously she's super busy, and I also had meetings scheduled. Maybe I'm going to meet her live in October. She's going to be at a conference in Boston, so maybe I'm going to go there. It's going to be more imaging, not just pathology specific. And she's also active in the Society of Imaging Informatics, SEAM, where radiology plays a huge role, but also pathology is another imaging specialty. That was an amazing guest. And yesterday I talked to another guest. He's a veterinary pathologist. He works for Aphoria, but he does not only work for Aphoria. Aphoria is an image analysis company. I mentioned at the beginning of the live stream that they've been sponsoring Digital Pathology Place for a long time. But he also does diagnostics, and he got in touch with Aphoria for an AI diagnostic project that they were doing in his diagnostic lab. And he fell in love with AI. He decided, this is something I need to learn. This is something I need to get more involved in. But he still has two jobs. He's a diagnostician, and then he does the AI and helps other get the AI for diagnostic purposes up and running. And the Aphoria is working with both human hospitals, veterinary hospitals, all different types of diagnostics, diagnostic applications. So he does that. He was interesting. I could relate to him because he's balancing two jobs, and he says it's tricky, but he didn't want to give up the diagnostics. He said he's a diagnostician in the heart, but AI is going to be the tool that's going to leverage diagnostics. So that's that. And next week I'm going to be in Poland, so you're going to see a different office behind. And also I wanted to tell you before we finish this live stream that this is like my favorite thing during the week. I was watching a person I follow on YouTube for a different topic, more the digital communications topic, and he read this book that I need to read as well, something about what's worth doing and what like lights you, gives you energy, what is the heckier thing. And this is my heckier thing. I love showing up, and I'm aware that this is a very not great time for most of the people that are my readers, which are in the US, and this is 6 a.m. But I consistently have Robert on the stream, and actually he was like, are we doing this? Because there was no invite. So I think something went wrong with the emails, but thank you so much. Oh, we have a question. Thank you so much for the question. Is hi doctor, what are your thoughts on clinical workflows powered by AI? So I have a lot of thoughts. Give me a specific thing that you're interested in, and I'm going to start talking about this thing. I think clinical workflows should be powered by AI, and they can be powered at different stages. Sorry, I don't know why I thought something was falling. Maybe my cup was falling. They can be powered. You can apply AI. So I see AI as leverage in general. So to answer this in general, and everybody who needs to sign off, thank you so much for joining. But let me answer these questions. AI is leverage. How can you use this leverage in your workflow? So my guest Richard Fox from Aphoria, he identified one problem, and that was Chi-67 counting and like evaluating, and he decided I could do that, and he applied AI there. And that's his advice. Basically, identify the problem where you want to leverage AI, like your lowest hanging fruit in terms of everything, in terms of workflow integration, in terms of price, in terms of regulatory concerns. Identify this one thing and start there. You're going to have to go through hurdles to deploy it. You're going to learn from your own mistakes and other mistakes as you do literature research. And I'm going to show you this tool for literature research next time, undermine.ai. But you're going to learn through the process. And then in the process, you're going to identify the next things that you want to address. But this is for an already established workflow where you're plugging in AI from the outside. There is an option to start in a different direction, like to have a digital first, AI first workflow. And what you're going to need to do, you're going to need to think of image quality. And there are technologies that are emerging that are actually direct digital pathology imaging. I'm talking to a company, Muse Microscopy or Smart Health DX. They are having a product like that they are evaluating it in like official studies, and that is amazing because the pushback that is legitimate and is heard often is like, why should I even bother if this technology is not direct to digital? Radiology is direct to digital. Logically, they're going to be ahead of us. They're going to be like leading, and they can do it because there's no like analog anymore. We are still doing our glass slides and then scanning them and then only applying stuff. And you can show numbers, you can argue, but with the analog taking out of the equation, that's digital first workflow, and you can design everything around it and then apply AI, use AI for different things. It can be diagnostics, it can be quality control, like workflow centric AI, workflow for case prioritization, workflow for sending cases. What is the thing that you want to use leverage for? Like for the chat GPT and the large language models, right? What is the thing? I read one paper by a friend, Candice True. She wrote a paper about chat GPT for digital pathology. Sorry, no, not for digital pathology, for veterinary medicine in general. And she was analyzing both human and veterinary medicine, and she gave percentages, how much time, and I think it was above 5% of physicians or veterinarian or any doctors, dentists, whoever, time is spent on admin tasks, on filling the documentation. Okay, can we use AI to help with extracting, like from recordings? How much money will we save? Let's do analysis and let's implement there. So yeah, that's a very fast, like it wasn't a straight answer. I hope it was a good answer. Let me check if we have any other questions here. I have even some more people joining later. So if you are watching the replay, give me a hi from the replay as well, and let me know where you were tuning in from, where you were listening in from. Also, for me to see who was there, but every comment, every interaction on this live stream brings it to more people who would benefit from this. My goal is to get this information to everybody who may benefit from it. You would not imagine, because we already immersed in this, reading papers and everything, how many people like have no clue what digital pathology is, even in the pathology world. They're like, I would like to get involved in digital pathology. Where do I even start? So you will start with my YouTube videos. How about that? But also there's going to be a course. So anyway, and we have a follow-up. This is interesting for prioritization in imaging. I can see use case in prioritizing patients in ED for junior doctors. Yes, junior doctors, you can, we just reviewed the paper. I don't know if you were online then. We had a computer-aided diagnostic tool that was helping with education of pathologists. So showing them a lot of cases and then making them diagnose, and then the tool would help. So basically, it is, okay, where do I want the leverage? What is the that is easiest to solve, that would free up resources to do more care, to be able to provide more care. So I hope that answers the question. And next time, please come with questions. I love answering your questions. Maybe we're going to do half an hour of the papers and then half an hour of discussion. And then I can engage with you a little bit more in the chat, because when I'm reviewing the papers, I can monitor the chat less. Thank you so much, Dr. Artford. And thank you so much for joining. And I will talk to you in the next episode. And now I'm going to log off on all the platforms. Thank you so much for joining. As always, also thank you for joining on audio. And I see that people are listening to those DigiPath Digest on audio as well. So I am committing to not missing any other future uploads, because everybody consumes information differently. If you enjoyed this episode, there are at least 2 other DigiPath Digest episodes already ready for you. But also have a look at the last podcast episode number 96, Achieving Work-Life Balance in Medicine as a Pathologist with Digital Pathology. And that was with Dr. Todd Randolph. It was a good one as well. He basically created himself a digital pathology remote position when it was not that trendy yet. So I hope to hear you in that episode, and I talk to you in the next one.